Let's do it. It's 5:30. Can we be called to order, please? Ow. Okay. This is the Human Service. Okay. Here, let me move this so I don't do the. You know, I talk in my hand.
You're going to spread your wings.
Okay, does that mean you're here? Okay. Courtesy of the floor, please. Anyone for courtesy of the floor? Check. Update on Graysdale, please.
Just wanted for everyone, grabbing that before, we do have a Graysdale brag book. It is a book of wonderful things that are said about Graysdale by families, fellow employees, etc. If you want to take a look at it, just pass it around. It's broken down by month.
And did you want to introduce yourself for people who may not know who you are?
Yes, I'm Raymond Soto. I am the administrator at Graysdale. I am part of the management company of Premier Healthcare Resources Incorporated, and I've been there since August 15, 2016. Okay. All right. Again, so sorry. When I sent the actual report, for some reason the second page didn't come out. So I'm glad I had copies for everybody to take a look at. Wanted to talk to you about the dashboard first, and then about handouts that I have afterwards. Basically, in looking at the dashboard, admissions are doing pretty well. We're at 672.3. That's over the 670 benchmark that we have now, and we're at 672 today. So we're doing well with that. We're also doing well with our referral conversion time, which is the time in which we get the referrals and come back. Finances are good. Our cost per resident day is at, sorry, I didn't have my glasses, $217.47. So we're doing really well with that. We're actually lower than normal. And Medicare reimbursement, we are doing really well with that as well, you know, compared to last month. Nursing PPD, we're a little bit lower than our benchmark at 2.93, sorry. And we're a little low in our RN hours. We're less than we were last month. We're up. LPN hours and CNA hours were also up. Agency, we are up in our RN and down in LPN and CNA. We are having some staffing challenges right now, but then so is pretty much every nursing home in the United States, along with every hospital. There is a nursing shortage, and we're doing everything we can to recruit more nursing staff, including our RNs, LPNs, and CNAs. We are working with HR to go ahead and come up with some creative ways to try to bring in staff and then retain them. I always say the first 90 days are your most important, and it's good to have a mentoring program to help them realize this is the place I want to be and this is where I want to grow with Graysdale, as well as other things such as tuition reimbursement, etc. So we are definitely moving in the upswing with regards to that. Okay. We had no deficiencies in January, no visits from the state. Everyone is aware that as of last November, we did have our annual survey. Last time I met with County Council, we were right in the middle of survey, so I didn't have anything to tell you. And then December was canceled on January, so we only received 3 low-level deficiencies. That is a wonderful survey because normally the average is anywhere state 7 deficiencies, national 9 deficiencies. So we did really well. I think we have 2 Ds and an E, and that's definitely going to raise our star rating. However, as many of you may or may not be aware, the star rating has been frozen since last November, and that's because we have a new survey process that the surveyors are learning to go into the nursing home that's more person-centered. So we are stuck at a 3, but realistically, if it was today, we would be 4 stars again. So we just kind of have to wait for that to come back to us, and that'll be for a full year. So you figure November 28, 2018, it should be unfrozen, and we should be back to normal. Okay. With regards to our quality measures, the only thing that's really of major concern is basically our pressure ulcers and our falls. I mean, they're up slightly. That might have something to do with staffing concerns, but again, we are working on that to make sure that we hire more staff so we can take care of our residents. With regards to our retention, I mean, in terms of our turnover rate going to human resources, we're a little bit higher than we were, about 3% all around. But again, like I said, we are working on that. And our star rating continues to be the same, 3 overall, 3 regulatory, 3 staffing, and 2 quality measures. I will tell you on our quality measures, even though we've had some little blips, overall our quality measures continue to go up in score. We are still at 2 stars. At the time, around this time last year, we were just at 2 stars with the danger of going back to 1 star, but now we've gained more points in certain areas where we've improved, so we are definitely at 2 stars and staying the 2, going to 3 stars. Any other questions on the dashboard?
May I ask?
Yes.
You mentioned the nursing issue. What is the status of the director of nursing position, and do we have one?
We do have a director of nursing position, and they're currently interviewing.
Okay.
Do you want to speak to this health choices?
Yes.
That's coming. Well, I guess, did anybody else have questions on the dashboard? Or the only other, did you want to speak to the behavioral health issues and the quality measures and how you're addressing those? Like that, or are any of the challenges that you're facing with that, or?
Well, the behavioral health issues, thank you for that. We do actually have a new company that is working with us on our behavioral issues. Prior to this, we used to have 3 psychiatrists and a psychological group. And the way it was is one psychiatrist came from 2 hours away, the other one would leave every 6 months for a sabbatical, and then there was the other one who would kind of take over for the first 2, but has just, I guess, said he doesn't want to do that anymore. And we had a psychological group that just really treated depression. And what happened with that is we're getting more and more residents who really need behavior management, more aggressive residents. The reality of it is we're dealing with individuals who are usually mostly from Northampton County who have some concerns, and we have to address them. Plus, we also work with AAA, and we do get some referrals, and we're trying to do that. So it was really hard, and we felt that we just weren't getting what we needed from the existing psychiatrist and psychological group, and we really needed to bump it up and go with an organization that is a combination of med management and behavior management, and it's called Med Options. I've used them at a prior county facility, which they still are in Cumberland County, and they've really shown to have tremendous results with dealing with the behavior issues, with reducing the psychotropic medications, which I know is a huge deal with everyone all over the United States. And how they divide it is they have a psychiatrist who oversees the nurse practitioner who specializes in psychiatric medicine. And what they do is they will oversee the med management part and try to do whatever they can to reduce medications that are unnecessary, or ones that they might feel that the resident doesn't have a true quality of life because they're not functioning at optimal level. And at the same time, they have a psychologist who's going to work with the behavior management piece and any residents who have issues, different types of behavior issues requiring redirection or just coming up with creative ways to deal with the issues to kind of redirect that negative behavior. And the 2 of them talk consistently and constantly about what's going on and issues that they're doing and seeing what each other's doing. Before, the psychiatrists and psychologists, they didn't even know the psychiatrists had admitted they never knew the psychological group existed, which makes no sense. So now we're going to have a cohesive group that's going to work on our psychiatric med management and our psychological behavior management. So we're very excited about them. They're starting the end of February, and they're really going to be just hitting the ground running and helping us deal with all of the residents that we have.
Can I have it, Madam Chair?
Yes.
In line with that, yeah, I'm glad you touched on that because I was just curious, are you seeing, I'm sure you are, an uptick in applications at the very least of elderly with medical problems but with very strong underlying mental health issues? Because as you know, when the state hospitals closed, the jail sort of became a backup for treating mental illness and some folks. But as the elderly, and all the graphs and all the demographics seem to point to the fact that there's going to be a large number, including boomers, and a lot of boomers, who are going to have, there aren't any places out there really that have addressed the issue that's coming, which is the elderly mentally ill. And I'm concerned, I mean, because I think Graysdale, as a public facility, is going to maybe be seen as, I can't get my mom, everybody's going to say no for a variety of reasons. Part of what you're saying now is part of that preparation for what you may see as coming down the road.
Yes, it is coming down the road. I mean, you do have your individuals who have, I mean, there's your ones who have had psychiatric behavior their whole lives, have been in institutions, they've been taken out, and they become older and they need medical care as well as further assistance with their psychiatric. But then you also see individuals who develop dementia, who were not like that 10 years ago or for even 5 years ago, and then things happen, and you're trying to help them deal with the dementia and all the behaviors that are associated with it. You know, you have many that can be aggressive, aggressive behaviors or just an isolating behavior. There's a lot of different types, but we do see an increase in those types of behaviors. And, for the most part, we try to do everything we can. As long as the individual is not a danger to self or others, we're going to do everything we can for them. And I will tell you, we do have those individuals who several of them are on one-to-ones. I've managed to keep the one-to-ones down. I've had as high as 14, but now I'm down to 6. And sometimes I've actually made it to 2, and then, we got some admissions in and things change, and that's tough because, like I said, with one-to-ones, that also focuses on your staffing, and it's hard.
Well, I see you getting, because sometimes folks forget, private facilities can say no to anybody.
Yes.
I mean, once they take them, they take them. But if they see someone coming in with a specific set and they have someone else with less, pocket profit is going to be, let's go with the person with least problems. And so I'm projecting that Graysdale is going to become the place where you may see a greater surge than other places. And I would just, as we go forward, if when you report, I would appreciate it if you'd occasionally give us an update on how that's progressing.
Oh, yeah.
I think I just see that as a major concern for everyone.
Right. That's part of our quality measures, so we'll be talking about that. And like I said, with this new psychiatric and psychological group, that's really going to give us a lot of the tools that we didn't have before to deal with these problems.
Thank you.
I was going to suggest if the committee's amenable, after they come in for a while and come up to speed, would it be appropriate for them to come and give us a little report on how they're doing or what they're seeing? Or
Sure.
you want to highlight that in a couple of months?
Yeah. No, they can definitely do that.
Yes, no, maybe so.
Sure.
It's up to whatever you want.
Since that seems to be the biggest area of concern.
Yeah.
And then you wanted to speak about the health choices?
Yes. Community Health Choices is a new program. Now, it is not going to come to us until 2020, but it's just a good idea to be aware of what it is. It's basically a program that is going to coordinate with Medicare. There's going to be 3 different types of managed care organizations. I don't remember exact names right now, but individuals are going to be allowed to join each one of these 3 programs. And, the focus is basically to go ahead and try to get them home and give them home care and do whatever they can. And that is a wonderful program because most people do want to be home, and we do understand that. But, in the same respect, they might be looking at individuals who, if they can go home, then they might not need a referral for a nursing home. Now, our population is largely long-term. We do have some short-terms, and the all likelihood that it's really going to affect us is probably minimal, but we still like to make you aware of what the program is because, it's out there and it's coming. It's in different counties now. If you look at the blue handout on the bottom, it tells you the different phases. We're phase 3, meaning all other counties. And we're getting updates from PACA, which is the Pennsylvania Association of County Nursing Homes, to kind of give us an update of where they are and what they're doing and how the process is going. They could also potentially, in the future, decide to look at residents in the nursing home to see if they are appropriately placed. However, That's almost redundant because right now, the way nursing homes are, we are supposed to look at any individual who needs to be discharged to home. They have a group called the 55 and younger group that they're going to look at and say, why are they here? What's going on? What are we doing to get them home? Plus any individual, of course, who can go home. Plus in AAA, we have the nursing home transition program. So all of those things we're doing already. So they might look at us and say, oh, well, you're already doing this and this is already happening and it may not affect us at all. But just to make you aware that the program does exist.
Any other questions?
I have two questions.
Sure.
One deals with the IGT program, because I haven't heard anything, and the reporting update and progress was, last year was February 5th deadline, okay? And the letter of intent to other counties, and at that time there were 19 counties, it was $2,416,792 million. That would have been offered to the Graysdale program under this infusion. My question is, where do we stand on that? Maybe you can't answer that right now, but are we in line for that money this year?
Yes.
And do you have an idea of what we need?
Yes, we are in line for that money. We have participated. We are part of the group. In line of exactly what we're going to get, I don't know, but I can find out for you. But we are definitely moving in that right direction. We're part of the participating county homes that's done that.
Second question was about the additional $200,000 because we meet our mix at Graysdale. Are we meeting those requirements? We get extra money from the government?
Yes, we are meeting the requirements. I mean, at this point now, sometimes the case mix index falls a little bit under, but we have to be concerned because although we try to get the case mix index to go up, we're also potentially affecting our star rating on quality measures. So we have to say to ourselves, you know, we need to get that quality measures up, but, you know, we want to get our case mix up. So we have to kind of balance the two and just do whatever we can to work in both in favor. But recently I just found that out, that the case mix index, if you try to go up, can potentially affect your star rating, your quality measure star rating.
Are we okay with our case mix to achieve the numbers that we project?
Yes, we are. Sure, no problem. Yes.
Yeah, a couple questions. I was looking at the 2017 unaudited financials that came in. I noticed that and these are unaudited, that we had an operating deficit of $458,681. Now, for someone like me, I can remember when that number was $7 million. So, you know, that number is good. But my question relates to the fines, fees, charges, and miscellaneous. That came in well below budget. Is some of that money still trickling in from last year? Because we had budgeted revenues there of $14.3 million, and you know, when we got the unaudited, it came in at about 13.3 or so. So that's about $1 million short. So I was wondering if you could comment as to the revenue situation and you know, specifically addressing that deficit number.
Yeah, that number actually, things are still coming in. That's part of our patient liability. It is giving on the total revenue our positive variance of $160,160. I think I can read it. I could find out more information about it for you, but in that respect, things are definitely looking better. And just to comment overall, although we did lose about $460, you know, we have that positive fund balance of $1.2 million, $211,181, which is very good, that we're very happy about. The loss, you know, is primarily, there's some things that did affect the loss, you know, the census we had at the beginning of the year and some retro pay for increases for the union that we had from previous years that was affected in 17. I can get you more specifics on that from the fiscal administrator if you'd like.
I was just looking for something general, but that's fine. I just, that number, the fees, fines, and charges for that to be that far below budget. And I do realize that things tend to trickle in, and maybe that number will come down a little bit.
Yeah.
The other question I had to do with the managed care portion. You presented it in a matter-of-fact way, but in York County and in Berks County, they're looking at this and thinking that it's just going to put them over the edge. And those two counties have begun exploring the sale process. And those are big counties, and that could potentially affect the IGT. So I guess the other question I had is that the preliminary state budget came out with no Medicaid increase for next year. Had you anticipated any increase in the Medicaid reimbursement as part of the budget? And how will you adjust given the fact that, the state's interested in funding bug domes rather than Medicaid?
Yeah, I mean, if I'm not mistaken, they haven't really increased Medicaid in several years, and I don't anticipate one this year, unfortunately. It's pretty much going to be the same, so there's not going to be any kind of adjustment for it, unfortunately.
Well, thank you.
Sure.
Just 1 second. I need to end this meeting at what time? 6:25? Okay, so in the interest of time, I'll take one last question because we have two other items that I want to get to. Is it desperate?
It was a question about the bed sale where that we're talking about deficits. We had an $800,000 bump from the bed sale of 37 beds. I'd like to know how that have it left. Where did it go?
I believe that. I don't. Yeah, I believe that was already absorbed in. I didn't hear anything about anything being left, but I could find out for you if you'd like. Sure.
Okay, thank you. No, I'm just worried about time because I was told I have to end on time, so thank you.
Okay.
It's my first time. Give me a 10. Thank you, Mr. Soto.
Thank you.
I didn't do anything.
Update on mental health, early intervention, and developmental programs division.
Honestly. This time.
Could you say your name, please?
Yes, I'm Tabitha Gardner. I'm the Fiscal Officer for Mental Health, Early Intervention, and Developmental Programs. I accepted the position back in August and have been working frantically without an administrator, which Sue will speak to next. In working with the deputy administrators, though, there have been requests for several positions, and we'd like to present that. There's 4 positions that we've identified as being needed. 2 of them are in the early intervention section. The first one will be a fiscal assistant, which would be a combination of fiscal duties and clerical duties, thus eliminating the currently vacant clerical position instead of filling it. It will enable them to expand and fill the program's needs on a clerical level, as well as relieve some of the fiscal duties that I don't have staff to cover. Then that way their fiscal duties would remain right there in the division, working day to day with the caseworkers, enabling them to move the program and the payment processes along a little bit faster. And it should save money. That specific position should actually reduce the amount of county dollars we're going to need. Can't quote exactly how many, but because there's a limited administration cap that early intervention receives, and currently with the clerical and fiscal charges to the division, they exceed that cap. This will help bring that down, so it'll be less county dollars. I can move just through each position, or
Sure.
That's really all I have to offer on this position, unless there's questions about that.
I would rather have you go through, and then if there's questions after.
Okay, the second position that early intervention is requesting is for a caseworker. Currently, their caseloads are running from 90 to 100 cases per caseworker. They should be somewhere around 60 to 70. Now, the caseworker position is something that we will likely be able to get the additional funding for. It's a matter of getting the position, finding out who and how we're going to fill it, and then making the request to the state. Because it is a reimbursable service, and it is a mandated service on top of that, we shouldn't have any issue getting funding for an additional caseworker. A position that I didn't mention in early intervention that the administration staff is asking for is a program specialist. And we've already determined flat out that we don't have a way to fund that. So we're not actually making that request officially, but it is something that they are saying is needed to manage the program. So that's early intervention. In developmental programs, they are requesting a program specialist. This person would take on all, would help spread out the duties that have drastically expanded over the last year. Developmental programs, they actually oversee all of the state waivers for the program, as well as we fund locally some base clients who don't qualify for those waivers. That has expanded by 60 slots. They're the same 5 staff people having to monitor, maintain, and oversee and enroll and disenroll 60 additional slots to what they were typically doing. So that position is absolutely needed. That position, actually, we have the write-up ready to go to civil service for approval. We would just need to get it county approval first. All right, so that's developmental programs. And in mental health, we are in need of an accountant in the fiscal department. There are currently 3 large processes that are not being done at all: risk assessment, cost settlement, and retained earnings monitoring. There just isn't staff to do it. So, and again, that in mental health, that position would be able to be fully funded under our current allocation. The only other request out of mental health is that we consider changing the salary scale for supervisory staff. They are having great difficulty maintaining supervisors who come up through the ranks, step out of the union into this position for a few dollars more, become overwhelmed by the responsibility, or get and leave, or find a better offer. So those are all the items I was sent with to share. I certainly can expand on any of it if there's questions.
Any questions?
Yes.
Thank you for coming and bringing this to our attention. The last few weeks we've had a recurring theme, and I'll ask the question, were these presented or considered as part of last year's budget, or for this year's budget process when we went through yes?
No.
No?
No.
Okay.
You did mention that it's 100% on mental health reimbursement.
Well,
I mean,
we would fully be able to cover it under our current allocation.
right.
Yeah.
What's the funding? I know mental health is generally high. What's the state for the early intervention right now? What do they give back for a position?
Well, it's 90%. They fund 90% of
That's
everything
okay.
through early intervention. Yeah.
And where's developmental programs at as far as your match funding?
Okay, in developmental programs, they are 98%.
Okay.
Yeah, 98%.
I have to bring myself up to speed on.
Yeah. Well, and it's changed since you were around last.
Yeah, a lot has changed, I found out. Okay, that's all I wanted to know. Thank you.
And can I ask the same piece on mental health, or what's the percentage of reimbursements on mental health?
98%.
So 98 on developmental and on mental health, and only 90 on early intervention.
Yeah.
I'll just ask the question then, because Mr. Werner said, if the state is going to pay for 90+% of this, and we need the positions, why would we not want to add them?
Well, the
Excuse me.
previous.
That for you if you'd like. Because it looked like you were saving money. He used it to make it look like you were not spending money. That's why. He
So-
counted it toward that 50 million or wherever he found that number. That's why. Well, I'm not trying to be wise, I'm trying to be responsive to his question. And that's why you wouldn't do it. It's the only explanation. That and someone may argue legacy costs. Because in some of these positions, it's not fully reimbursable with respect to and I'm right about this, Tabitha, the fringe benefits are not fully reimbursable by the state, but they're up to 80% in some of the cases.
In most cases.
It's a big number.
Yeah. There's only that little retirement piece that's not allowed, and it's not retirement funding,
Well,
it's the retirement health care.
And Mr. Cusick, we're going to fill as many of those types of positions as Human Services tells us they need.
As we should.
Yeah.
Yeah, and the previous leadership in mental health, developmental programs, and early intervention had a different take on the budget as well. They were much more conservative than the view I take on it. We are part of the block grant to have the freedom to move the money around where it's needed, and they hesitated to do that. I am certainly completely for that so that we can fill the needs that we have. Again, just looking for leadership to conspire with to make that happen, and Sue is the reason I'm here, so we can speak about that in absence of an administrator.
Okay, thank you. Matt?
Obviously, like Mr. McClure said, we have some costs maybe on the back end of it, but by being shorthanded and we're getting the cost of turnover and training people, and of course, just not being able to do the job as well, how many more positions can we fill, through state funding and that going forward? I mean, are we right up against how many they would fund, or?
Well, we went through all of that. I went through all that with the deputies, and can we fund it, can't we fund it, how do we fund it, is it necessary? Because I had initially told both of the deputies in EI and in developmental programs, no way, no new positions. Of course, I was new at the time. I've had some time to actually dig into the books and look at what we have and what is reimbursable, what isn't. And in the case of early intervention, for services, under the mandated services, we can request additional funding. It's just really that simple. But under administration in that same area, it is what it is, and when we exceed administration, it has to come out of county dollars. So so these 4 positions that I'm asking or presenting to you, we know we can fund.
Yeah.
So,
I would suggest that this be put into a form presented to the personnel committee.
that's what I was going to suggest.
I don't think I'm not going to try to speak on behalf of the committee, but I don't see that any reason why we can't do this.
Okay.
If there's no, I just think you should write that up as well. And I know I'm planning to go over and visit tomorrow, so I'll get to spend more time with you and hear what's happening. And
Okay. Yeah. We actually have 2 of the positions already written up. We have the specs written up. We had them initially reviewed by the state. So we've got 2 of the 4 written up and ready to go.
yes, I would send them over then.
Okay.
Thank you for your time.
Okay. No other questions? Thank you.
Update on all of Human Services. On day 45, day
12.
what? Oh, sorry,
10.
day 10.
Day 10, that's okay. Good evening.
Say your name.
Sue Wondolowski.
We are. So we say it right next time.
Sue Wondolowski. Yes, Kevin Dolan's having a little trouble with that last name. But yes, what's that? No comment.
Okay.
We have had a busy first 10 or 11 days, but it is going very well from my perspective. I would say the top few priorities that I have had are filling vacant positions, getting approval for positions that we need to add in order for people to get their jobs done. Staff retention is a huge issue at the moment in Human Services. Working with all of the administrators on succession planning, or I have been amazed at how many folks I have met that I didn't know who are not that far away from being able to be retired, and they're all in the same building. So that's a big focus for us. And it seems like I very much seem to have buy-in on that, although it seems like a new concept, which sort of surprised me. So we're working on that. The MHMR administrator that Tabitha mentioned, that has been vacant since the summertime. I'm not sure exactly when.
July 28th.
July 28th. that job was posted for twice in the fall, and my predecessor, by November 4th-ish, decided to not fill the position to afford her successor the opportunity to fill that, which on one hand is appreciated, and on the other hand has really left us in not a great place. So Brian Watson is our acting administrator. He is the deputy for mental health. He is eligible to retire in May. One of his top supervisors resigned, and her last day was Friday. So that department has been our most urgent focus. There was a lot of issues, I won't even get into it, between Human Services and HR in the last administration, and I have worked with Liz Kelly and Shauna Shriver in HR to expedite this process as quickly as possible. So that is my top priority in terms of, filling that position immediately. So we've already reached out to the MHMR Advisory Board because they have to have some level of involvement in that process as well. So, and even though it's an MHMR administrator, they also oversee developmental programs and early intervention. We have a couple of really good internal applicants, which is frustrating that we can't move quicker, but we're going as quickly as possible. Questions about that?
Do you have similar issues across the board? I mean, you identified mental health as the toughest area, but is that?
It's not the only area. It's just that they are lacking that leadership. And given the fact that the acting director can retire in a few months and one of their top supervisors left, I prefer it to not crumble, before we get that done. Children and youth, listen, that's right. I mean, that's always going to be an issue, but we are working on some things, and there's some new initiatives to try to work on that retention, and I think for the most part folks are doing a good job. But I was told that last year they hired 25 new caseworkers, so the turnover has just been astounding. Somebody just referenced the and I promise I will be quick-ish. I only have one more thing after this. Somebody referenced when the new laws came out after Sandusky, how the folks who put all that legislature together said, here's the 20 new laws, roughly, and it's not going to cost you any more money to do this. So you've heard it. Kevin's been here, right? Calls have doubled. So, yeah, it's, ludicrous.
That hasn't changed.
No, we had children and youth. We had a little visit from the Auditor General yesterday. If any of you didn't see it on 69 News, you can Google it. It'll be there. So yes, across the board, it definitely is an issue. But we're at an okay place, children and youth wise. Mm-hmm. We need to get this mental health stuff done right away. So we are. And the only other department I wanted to touch on briefly was the aging department. As you all know, that is where we got the failing grade from the state in the fall, and John is not yet back. Lori Greco, who is the deputy director, has been phenomenal as the acting director. I've told Mr. McClure numerous times, I really cannot sing her praises enough. I've told her as well. So, I mean, she just has done everything she can. First of all, to learn the entire job, of which she didn't know, to dig out of a very large hole, which is literal and being kind. So the state is coming next week on Thursday, and I think the purpose of that primarily is to see how we're doing, but also to advise and recommend different systems and ways that maybe we can avoid getting into these situations again, some of which are very easy to fix and are very obvious to me coming in. And as Mr. McClure told you the last time I was here, it's not acceptable, and it will not happen again.
So could you clarify that they're only coming to review that department?
Yes.
Okay, thank you.
Yes, just aging. They did approve, they originally did not approve John Mailer's corrective action plan, but once they saw the progress that Lori Greco has made on getting through some of those things, she sent me an email last week, I believe, that indicated that the state would in fact approve that plan, and so now they're really just monitoring how we are doing on that plan. And so we're working on that. There's a few vacancies in that department and some personnel issues that we are working on. We've had a promotion and some vacancies, so certainly that's as much of a priority as the MHMR administrator, but they have an acting leader who's doing an amazing job.
Okay, any questions?
No, I'm okay, thank you.
First of all, I want to applaud you taking this on, and also, I'm glad you're really jumping on these positions. I mean, it's critical, and it's just what the county does. Whether we like, the other thing is, I have to give you credit. I mean, it's been mentioned about succession planning. And I'm sure you've seen, you can get really caught up in just the day-to-day explosions. We had a chance to chat before everything. Every day there's a new explosion going on in crisis, and it's tough to go from micro to macro. Right. But I learned, or at least I remember that division heads and some of the folks, they don't think much about who's going to take my place when I leave. They sort of want to run it up to their date, and then it's like, boom, I'm gone. And so I congratulate you on understanding that and looking into it. And I know hopefully they'll give you some support in that. Not that it's something they enjoy talking about or think about.
It's not a choice.
Well, good. And I think you'll find most council people, or I'm sure the administration will back you up on that. I mean, the department does a great job for the job you have to do, but sometimes folks forget that, you're appointed, not anointed. And I think you have to remind them now and then.
Understood.
Thank you.
Thank you.
Anybody else have any questions?
With some of the turnover, and I know we're trying to do all we can to get people to stay, and I think that's great. But should we also be planning on, like, some of these things they get burnt out on, and just see that that's not going to change, even no matter how much you change a position?
Sure.
That some positions are designed that would turn over, and we attract them that way, knowing that that's going to happen, and
right.
If we set up kind of like a parallel program of people wanting to stay and people to move up, almost as a design plan when they get into it, and maybe we can keep them there a little bit longer if it's a design plan, and so instead of a year and moving out, if it's maybe a design plan that they say a year, 2 or 3 years,
sure.
But they still see that light at the end and maybe slow down some of their turnover maybe.
Well, I know that historically, in Northampton County specifically, at Children and Youth, I was having a conversation with one of the caseworkers. There was a day, when there was a waiting list. That's not the right word, but there was you had to wait your turn on the civil service list, and it's just not like that anymore. So there's a lot of factors. The turnover has been extraordinary since 2014, 2015 with the Sandusky stuff.
Sure.
And part of it is not the amount of work, which has doubled. It is also the pressure of these young folks having to make life and death decisions about whether or not kids are safe. And some people just have a hard time sleeping at night because there's not enough time to do that job correctly. So there's a lot of factors, and you're correct. There are some positions that there'll always be a turnover. I think the goal is to make that a little longer and have a situation where people can move up in the ranks.
Yeah.
So.
If the rest of the committee has spoken, I have a question, since I'm not a committee member. Okay, not a question. First of all, I think I warned you.
For quite a while.
You have 5 divisions that are a handful, absolutely. And I commend you for doing what you've done so far.
Thank you.
I handed you the letter from the governor's office that will help.
Okay.
And it will also work with Dee Pasquale, the Auditor General, who's going to be doing you a favor, hopefully, by eliminating some of the paperwork and helping.
That is his recommendation.
The meeting that was done, and I'm only going to speak on the children and youth right now, because I know Kevin's got his hands full.
Sure.
But the meeting that was done was with Bob Freeman, State Representative Bob Freeman, Director Rose Farron, the main team for children and youth programs, Julie Bader, CPS Director, Lisa Hand, and Pat Himmelwright. These are all your people. Three things that were considered was, one, the civil service programs.
Yes.
That's going to be hopefully fixed, and that's been a critical part of the problems.
Absolutely.
Okay, ease of facilitation. Second thing is reduce the forms and paperwork, which I understand. You're talking about the stress levels, which that absolutely supersedes all this. But last but not least, there was some mandatory training that was involved. I think they're going to ease that up too.
Okay.
So I really think people are starting to take notice, not just on it has to be on the state level.
I agree.
It has to come in and it has to help you.
Right.
You can say all the things you want to do. You can hire all the people you want for caseworkers, and they're still going to burn out because no one's changing the environment.
Yep.
We have opioid problems. It's getting worse, and I commend you for what you've done so far. And if there's everything I can do, along with State Representative Bob Freeman and the people that I know, Congressman Cartwright, will absolutely extend our services to you.
That's appreciated. Thank you.
Thank you.
Thank you.
Do we have anything else off the agenda? Any items? I hear a motion to adjourn.
Second.
Second. Coffee break. Adjourned.